And today I'm going to, so this is kind of getting the whole discussion to an end, re-looking at the theme of our conference, advancing disability empowerment through inclusive rehabilitation and mental health innovations for a sustainable future. So I was kind of unpacking and looking and thinking as you also were presenting. So in this session, basically, it invites us to reflect on the reality that rehabilitation, I like this statement, rehabilitation is not simply about restoring function, it's about restoring dignity. It's about restoring independence and opportunity. So if anything that we are doing does not end into restoring dignity, independence, and opportunity, we haven't started. And mental health is not just about care, it's about empowerment, resilience, and inclusion. And if those elements are non-existent, then it means there is a huge gap. So in the process, I'll try to identify key lessons, strategies, and pathways to building a future, a good future where no one is left behind. So basically that's our presentation, and I hope I'm going to finish on time. So let's look at inclusive rehabilitation. What are the principles and practices? Number one, accessible infrastructure where we use universal design. Most of us when we're presenting, I think we raise this issue. So whatever we do, and when we are talking of accessible infrastructure or accessible services, we are not only talking about the ramp. Most of us will always think of the ramp, which is very easy. So any facilities, equipment, or services, they need to be designed so that everyone can use at any particular time, regardless of our circumstances, without any retrofitting. Last month, I was doing an institutional audit for an international organization called Young Africa International, and they are represented in Zimbabwe. So I was looking at the Young Africa Zimbabwe organization. And what I liked about this organization is they asked us to do a full institutional audit so that to see to what extent are they mainstreaming disability in their activities. So we're looking at their policies, we're looking at their programs, because it's a TVET center. We're looking at their programs, how accessible are they, the curriculum, we're looking at their capacity, we're also looking at the physical accessibility, and we're also looking at their websites to check their inclusivity. So it was a full package, and for me, that's a full commitment if we do a kind of a full institutional audit. And we are going to do the same next month in Zambia for one of their member countries as well. So to me, such kind of an organization is taking inclusion very seriously. So when it comes to the physical, we are looking at everything, the ramps, the doorways, the non-slippery floors, clear signature, adaptive toilets, the lighting, everything that we can think of that can have an adverse impact on persons with disabilities. So, like for example, there's a rehabilitation center in Kenya, and they installed tactile pads and braille signage to make navigation easy for blind and low vision clients. So that way it becomes very easy to make sure that we have really prepared for a person. I was sharing with somebody this afternoon to say, 3 months ago at CBM Global Zimbabwe, where I work, for the first time, we had one of our staff members that was recruited has no vision at all. And so it was our first time as an organization. So what did we do? As soon as we knew that is the one who got the job, we sent him a form to indicate all his access needs. What is it that you think you need in order for you to start work? And he indicated that he needed JAWS. This is a software that he uses on his laptop, and he wanted an office where there's not too much noise. So we had to adapt one of our buildings to make sure that it's okay. And then we bought everything, the laptop that he said he wanted. So as soon as he started, everything was in place. So we never had any challenges with him. Why? Because we made sure that access needs were addressed. And so we are saying accessibility is for all. No one should be left behind. And when it comes to, and we really need to make sure that we are doing it right. Because if you look, even here in this country, I was looking at some of the ramps, I call them death traps, because they are so steep. And you wonder how can a wheelchair, even an electric wheelchair, are they able to maneuver that? So we really need to be very serious. And then, number 2, multidisciplinary teams with shared goals. Issues of inclusion is not a one-person band. It should be multi-sectoral, where we bring all together all key stakeholders, be it psychologists, health workers, any person that we think has got a hand in terms of making sure that there is inclusion. And this team-based model, it fosters the holistic care, ensuring physical, emotional, social, and communication needs are addressed. Otherwise, if we don't look or think holistically, there are chances that we can miss out on other things. Like, for example, in Bangladesh, the teams, when they're working on one of the aspects, this is an organization in Bangladesh, it included both medical and social rehabilitation officers working together to co-develop a care plan for their clients. This was an organization working on people with multiple impairments. So because the needs also they increase, so you really need to make sure that we bring everybody on board so that we can work. And then number 3, community-based rehabilitation models. We are very much aware that CBR, they need to be closer to people. And now we are moving to CBID, CBID. What does it mean now? I'm getting confused. Where we have inclusive community-based rehabilitation. So it emphasizes on local capacity, empowerment, families, communities, and sustainability. Why communities? Because people live in communities. And if your communities do not appreciate any efforts that we are making, it's as good as a loss. So we need to have a buy-in from our communities. They need to understand what we are doing, why we are doing it, and we should co-create the knowledge together with our communities. We shouldn't do, the yesteryears where we would think of a program. Maybe I'm in the UK, I think of a program, I put everything together, and then I bring it in a suitcase to say, okay, community A, this is what we think you want to do. And obviously, people will not take it because they are not part of it. And in most cases, we lack the cultural contextual. A good example is in Zimbabwe. An organization came from the UK. There was an outbreak of diarrhea. So they set in the UK to say, okay, we heard Zimbabwe, there's an outbreak for diarrhea. So what should we do? Okay, we need to build a toilet on each homestead. So they came, they built a toilet each. After 2 years, diarrhea did not disappear. And then they came back to the communities. They saw the toilets were still intact. They were not being used. People were still using the bush system. That's when they questioned, why are you not using the toilet? Are you not appreciating? And they said, according to our culture, a male and a female cannot use the same toilet. What about if I'm a daughter-in-law, but I'm not sure whether my father-in-law is in the toilet? What will happen if we bump into each other? So they ended up not using the toilets. That's why it's important to understand the cultural context so that we can come in with a more specific intervention strategies. So we need, example, a Japanese CBR model that I looked at. It deployed trained local volunteers who support elders and persons with disabilities through home visits, assistive technology support, and social inclusion. So they were looking at all aspects, the physical, the emotional, and the social aspect, and even the medical component of people's lives. And then number 4, continuous feedback from persons with disabilities. Remember our Our motto, nothing about us without us. Self-representation is key when we're working with persons with disabilities. Like for instance, in CBM Global, we are not even allowed to do any activity or to come up with an idea without engaging persons with disabilities. It won't be funded. That's a given. So, inclusive rehabilitation is not static. It's something that always evolves, and we need to move with the times. It must involve both. It must evolve based on direct input from users. So we need to engage right from planning stage up to implementation and evaluation. Because if I'm the user of a service and I don't understand how this came about, it becomes questionable. Regular feedback loop through interviews, surveys, participatory audits, and anything that we can think of, it helps understand that we are really working together and engaging with the end user. Like for instance, in Uganda, a quarterly review with the disability advocacy groups helped redesign intake procedures to better serve deaf clients. So it's only through engaging with people that we can meet their real needs, not the needs that we think are their real needs. Then, issues of mental health innovations, empowering through inclusion. Remember, in our theme for the conference, the issues that were coming out is the issue of rehabilitation and mental health. They are all intersecting to serve persons with disabilities. So, number one, what can we do? Telemental health for remote areas, especially in most low-income countries, Zimbabwe, where I come from included. We have realized that digital platforms, especially WhatsApp and SM messages, Zoom is questionable in some areas where there's no connectivity, but for WhatsApp, because we now have many service providers, it's becoming cheaper and cheaper, so people can actually manage that. So we need to use channels that are easy to reach, and these can be used to deliver any counseling or psychosocial support to persons with disabilities, especially in the hardest to reach places. And like in Zimbabwe, they now have like community centers where they can now have internet, and the community can come in and use the internet to look for jobs or to just get any information. So these are the centers that can also be used. We need to overcome barriers such as transportation, stigma, and shortage of local mental health professionals. I don't know in other countries, but mental health professionals and psychologists, there are quite few in most of the countries, especially our low-income countries. So it's something that we really need to advocate as agents of change within our higher education institutions to identify areas of need within the disability framework, so that we can also help get relevant stakeholders when we are working. Like for instance in Zimbabwe, during the cyclone in Dai, which affected several communities, there was telecounseling. It was a pilot project where communities were given tablets or phones, and then so they were kind of distributed to several points, and then people could actually go to those centers, and then they can use those services so that they can get support, counseling, and anything that they wanted. And the good thing was they were using local languages, because in most cases we hide information by using a foreign language that our local communities cannot understand. So it's very, very important. Even when we do our studies, I know the academics here, the organizations here, yes, you can have a report for your funders in order to impress them, but you also need to think of the communities that we're working with. Easy to read, local languages, then they can also appreciate and understand what we also were doing. And also working with them. Remember, nothing about us without us. So it does not only affect persons with disabilities, even any end user of the project that you are working with, you need to work with them. And peer support group led by persons with lived experience. I always say, the person who, yes, we can talk about disability in this room, But as long as we have not lived the experience, we can only imagine. Even if they are persons with disabilities themselves, their experiences are totally different depending on their circumstances. I always tell this issue to say, even if you meet two women, two widows, their stories are different. If the man was abusive, someone will be singing, "Hallelujah, thank you, God, for eliminating this barrier in my life because he was abusive." But if the man was good enough, the other woman will be crying every single day, thinking, "I wish this man could come back." So circumstances are always different. So we need peer support. So we need people who have navigated mental health challenges to facilitate such sessions and have one-on-one mentoring because they understand better. And these peer-led spaces, they foster trust, reduce stigma, and build communities. If I'm a married woman and I go and try to facilitate on a group of single women, they'll be thinking, what is it that is in for her? We all don't have husbands, but she's coming in. So they can start questioning about that. So we really need to use people we have the experience. Like in Kenya, there was a program that trained youth with psychosocial impairments to lead resilient cycles, which have led to increased school and work participation. Because it's coming from someone they think they are in the same circles, so it becomes a lot easier for them. And we've got a resilient circle here. So what are we saying in terms of the resilient circle? This, number one, what really matters in my life is coming from the end user is the one who is asking. So they are looking at themselves, they are mindful of anything around them, they are aware of themselves. And we also have, what do I notice about my eyesight is not that good. What do I notice about my health and well-being? So they are looking at issues of self-care, and then what do I want to do for myself? They are now looking at issues of professional care. And then who is part of my healthcare system? They are now looking at the community. And who is the part of my community is now the healthcare is about the professional care, and then the community is who is in the community that can actually assist us to change. So they are looking at all these issues in order to support their level of resilience. So it is the community that can change our lives. We shouldn't even go far. The people within our community, they've got the expertise. But I think at times I always say, I come from an academic background. Academics, they always think they know everything. And we need to change that mindset and learn from our communities. Okay, as I'm getting to a close, number 3, mind-body therapies. It helps in terms of mental health innovations. Alternative therapies such as trauma-informed yoga, dance, art, drumming, and journaling, writing. Some people, they are good. When they write something, it actually comes out of their heart. This improves emotional regulation and mental wellness. So it's quite important to look at that. And especially for children with intellectual impairments and those with trauma histories. And I know some can actually use photography to just go and take pictures. That makes sense to them, and they can have a good explanation of why they've taken those kind of pictures. You can actually see what is it that makes sense to that particular child. Like, for instance, there was a pilot project in Malawi which integrated storytelling and music into inclusive therapy sessions, helping reduce anxiety among deaf youth. And then number 4, accessible apps for mental health, mental wellness support. So we can just think of developing and coming up with apps that can actually help. Like, for instance, there's a project that I'm doing in collaboration with Open University in the UK to develop a disability app that can actually help teachers who are teaching children in mainstream schools in terms of inclusive practices. Very easy, plain language that you don't even need to go to a university to understand that. Simple, and I always say that simple is smart. Complicated is dull. Okay, I'm not going to talk about this much. So the roadmap to inclusive empowerment, as I get to a conclusion, what is the roadmap to empowerment? Number one, assessment and design, needs analysis with persons with disabilities and providers. So whatever we are doing, let's look at the people that matter most, that we need to bring together in order to come up with solutions that can actually address the challenges we have. So number one, conduct participatory needs assessment that involve persons with disabilities, caregivers, because they spend most of the time, especially when they are children, with children with disabilities. So they are quite useful. Community leaders and frontline health workers, they all need to be there and work together with them. And any other stakeholder that we think can also be part of our assessment. And let's use mixed methods as we are doing that, so that we appreciate, be it focus group discussions, interviews, facility mapping, maybe storytelling, narratives, picture, like what I was saying, pictorial ethnography. And let's identify gaps in the access, quality, and inclusion across physical and mental health services that can help us. You get this. You can read some of the examples when you get the slides. Number two, co-develop and test inclusive services as a pilot. So we need to develop and test small-scale localized models such as inclusive mobile rehabs, virtual mental health services, or peer-led therapy. And we need to co-create the tools like sign language supported intake forms, visual mental health screening tools, or culturally adapted CBT modules. It's very important to make sure that anything that we do is culturally sensitive. Like for instance, in Zimbabwe, we use the RAT, the Wide Range Achievement Test. We still use that. But the interesting part of that test is it's a cognitive test or psychology test. The interesting part is there's one question which asks about snow. Why on earth would I ask about snow to a child who lives in a humid place like this? They will never experience snow. And they don't even know what snow is, but there's a question. So the child will fail, not because their IQ is low, but because they don't have an idea of what we are talking about. And then we need to, there's need for integration, embed into routine rehab programs. Let's move beyond pilots by embedding inclusive approaches into existing health and rehabilitation systems. Let's not try to reinvent the wheel. Let's use existing systems within our communities and we work together. That way, there's a lot of buy-in when we do that. Let's train health personnel on inclusive practices, strengthen referral pathways, and update our standard operation procedures together with all our stakeholders. And let's include assistive technology in everything that we do, counseling and community outreach in core health service packages. That way it helps us to embed. And then I think that's the final, I hope so. Monitoring and track outcomes. Measure what matters. And what is not measured does not exist. In our African context, I don't know other contexts. So we need to measure physical functioning, mental health indicators, service satisfaction, stigma reduction, and empowerment. And that way it becomes easier, and we have clear indicators on each aspect that we are measuring. Let's use accessible monitoring tools. If it's necessary to put in braille, visuals, audio, videos, anything. And let's involve organizations of persons with disabilities in data validation. Let's adapt based on learning cycles and lived experiences feedback. That way it helps us. And then advocates and scale up. Let's publish results and grow rich. Number 1, package results and lessons learned into policy briefs, case studies, and conference presentations so that we share. Let's engage ministry, donor agents, organizations of persons with disabilities, academic institutions, and anyone that we think can help us, our communities, so that we can model our national, at national and regional level, and even at community level. Let's build coalitions for funding. I now know funding is a huge issue after USAID decided to disappear. So we really need to make sure that our legal reforms, our systemic change, so everything that we have been doing here as we go back to our countries, to what extent are we going to influence policy? To what extent are we going to influence practice? If we don't do that, it's just as good as we came here to enjoy, and then we eat, we go back and relax. Okay, so take away, we can forget everything that I said and remember this. Number 1, empowerment requires physical and mental well-being. Number 2, partnerships across disciplines create impact. Number 3, engagement with persons with disabilities is essential. Number 4, digital tools expand reach and accessibility. And number 5, sustainability lies in policy, capacity, and scale. And what I was saying is a way forward. Let us all put our hands and minds together. Let us be who we are. Together we can, yes we can. If not sure, please ask in everything that we do. If we don't know, we ask. Okay, these are some of the work that I've been doing. Now, this one, the first one, towards inclusive education in Zimbabwe, perspective and practice, that I did with a colleague, Sediso Mikaelo Mokaele. It came out this year, the Handbook of Disability and no, not this one here. It came out this year. And the second one, the Routledge Handbook of Post-Colonial Disability Studies. It also came sometime this year as well. And the Routledge Handbook of Disability in Southern Africa, it came out in 2018. And the Routledge Handbook of Disability Activism, it came in 2019. That's the one that won a global award as an outstanding book in social sciences for Taylor and Francis. I thought you were going to clap hands for me. And currently I'm working on a project, the Handbook of Disability and Education, to be published by Edward Elgar Publishing. And anyone who is interested in contributing a book chapter, you can contact me as long as it's on disability and education. It can come into the book. And then finally, in next year, in November, there's going to be an 8th African Network on Evidence to Action on Disability, AfriNID. This is the biggest African disability conference. It happens every 2 years. And Stellenbosch University houses the idea. So it's between 24 to 26 November 2026 in Dar es Salaam. And the theme is Realizing Disability Potentials in Africa, Opportunities and Threats to Full Inclusion in Trying Times. And it attracts people across the world. That's the interest of it. But the information that is required is Africa related. So any research that we are doing, the call is out. We can Google and then we can get and do what is needed. Thank you very much. I really appreciate for your listening. Thank you.